Hi, this is Dr. Terry, and I'll be talking with you today about an introduction to psychiatry. This slide set is designed for the developing physician, although its uses may be expanded in general for teaching first-year medical students about psychiatry in the context of a general clinical skills course. Our session learning objectives are the following 5 points. First, we're going to be talking a lot about definitions and vocabulary for psychiatric presentations in primary care. From there, we want to prioritize and recognize psychiatric symptoms in primary care patients and cases. We're going to correlate common patient presentations with indications and warning signs for screening instruments. Then we're going to take a look at common screening instruments that are used for anxiety, depression, substance use, risk assessment, and memory loss. Finally, we'll develop and write the basic components of a mental status examination as it applies in clinical documentation. This first slide includes a number of definitions that we use in psychiatry. I'd like you to be familiar with every single one of these definitions. I'm going to run through them. Feel free to fast forward this part if it's moving a little bit too slowly for you. First is the word somatic. Somatic is an adjective that could have to do with anything in the physical body or physical symptoms. Osteopathic medical students might be familiar with the term somatic dysfunction, saying that there's a dysfunction having to do with the physical body. A person might be said to be somaticizing if they have a lot of physical symptoms. Delirium is an acute change of altered consciousness and cognition that is usually due to an underlying medical cause or substance. It's considered a medical emergency and an acute presentation. This is different than dementia, which is a gradual and often irreversible cognitive decline. Anhedonia is a loss of interest or pleasure in activities previously enjoyed. I would even take it a step farther to say that an, as the absence of, and hedonia, pleasure, is a complete absence of pleasure. This is a state in depression that's usually quite severe, where really nothing is enjoyable. An illicit drug specifically refers to substances that can cause an altered state of consciousness, but whose use or possession risks legal or criminal consequences. Many drugs can cause altered states of consciousness, but illicit has to do with local ordinances and what's legal to transport, to obtain, to use, to carry, or to sell. The next 3 terms, intent, plan, and means, often refer to either suicidal or homicidal ideation, the 4th term in this next block. Intent describes a purpose and determination to complete a task, often used in assessing risk. For example, if a person has suicidal intent, that means that they're determined or plan to complete suicide. A plan describes how a person would do it. So this can relate to suicidal or homicidal ideation, and it's often a sequence of steps or events that could be used to carry out the task. Arguably, a person who has intent but doesn't have a plan is going to be much lower risk than a person who has an intent, a plan, and the 3rd thing on this list, means, the tool to carry out a plan, often used in assessing risk. For example, when asking about suicide or homicide risk, the physician must ask about intent, plan, and means. And if a person has intent and plan but no means, or intent and means but no plan, although that wouldn't make a ton of sense, it's still possible, it's going to be a much different risk stratification than if they have all 3 of those items. This is much different than the term we see thrown around a lot of ideation, which is a vague term that describes a wide continuum of thoughts ranging from brief consideration all the way to a detailed plan. For example, if a patient has suicidal ideation, that doesn't really tell us if they have an intent, plan, and/or means. That's for the physician to describe. Cognition describes the mental ability to think, which is to learn, to remember, and to perceive. Depression and anxiety are what I would call colloquial terms. They describe emotions. Anxiety in itself is not a diagnosis, nor is depression. Generalized anxiety disorder is an example of a diagnosis, as is major depressive disorder. And finally, the DSM-5 text revision, or DSM-5-TR, published by the American Psychiatric Association, is used for agreement for inter-rater reliability in psychiatric diagnostics and it's used internationally across multiple fields of research and clinical application. Now, let's take a look at some background understandings. We spoke here about the DSM-5. This is an example of being the #1 bestseller in psychiatry. And in primary care and emergency medicine, up to a third of patients that seek out primary care services or emergency services have mental health diagnoses. And of those, half or 3/4 of these diagnoses might be undetected or untreated. What I want to drive home here is that the most frequent utilizers of primary care and emergency services are going to be patients with comorbid psychiatric diagnoses and symptoms. We also remember that physician training, in particular osteopathic training, emphasizes the importance of the mind, the body, and the spirit, and how those impact a person as a whole. You'll hear me say this again in this presentation, but I really want to emphasize that there is no such thing as a psychiatric patient. However, there are patients with psychiatric symptoms or psychiatric concerns. If we look at unexplained symptoms, about half of all outpatient visits involve patients with physical symptoms, and a third of these, here's that vocab word, somatic symptoms, are unexplained and don't correlate well with a known physical diagnosis. The prevalence of anxiety and depression increases in patients who have unexplained symptoms or for patients where a diagnosis cannot be easily found. We can also look at common functional symptoms and common functional syndromes. The common functional syndromes describe mental health diagnoses that co-occur with common functional syndromes, such as irritable bowel syndrome, fibromyalgia, chronic fatigue, even temporomandibular joint disorder. What we want to look for are these overlapping symptoms, especially fatigue, sleep disturbance, musculoskeletal pain, headache, and gastrointestinal problems. These are such common issues that present across multiple diagnoses, so it's important for us to look at these as potentially additional treatment targets. Now, mental health screenings are something that every first-year medical student should be familiar with. These screenings are going to be brief surveys, normally given in a primary care setting, to help for early identification and monitoring of various disorders. They are commonly administered by medical assistants, by medical students, by nurses, by physicians, and they primarily serve primary care purposes. As a psychiatrist, if someone is seeing me, it's safe to say they might have already been screened, and that's the reason they're seeing me. So it doesn't make much sense for me as a psychiatrist to provide a screening for someone to see a psychiatrist when they're already seeing me or another psychiatrist. As a medical student, you should be familiar with the names, the indications, and how to apply common screenings identified here. Screenings might be indicated by insurance, by just standard what we do in our practice. They might also be something that reimburses well, and it's an insurance reason for why we do that. Some screenings might be universal, where every patient of a certain age or demographic gets the screening. Others might be more targeted. Say if a patient has a chief complaint, we give that screening. Warning signs might include, of course, things like delirium or dementia, family history or social history of similar diagnoses, abrupt changes in attention, mood, speech, insight, orientation or memory, or symptoms that are above and beyond what we might expect on the screening. So we're going to be exploring screening strategies for anxiety, depression, substance use, risk assessment in general, and memory loss. I want these to be a part of your toolbox and incorporate it into your history taking and exam. Let's talk a little bit first about anxiety. Anxiety, again, is not a diagnosis. Anxiety, arguably, is something that we all experience at different times in our lives. However, an anxiety disorder is where that anxiety begins to cause symptoms that interact and interfere with a person's function. Furthermore, to be diagnosed with an anxiety disorder, or most primary anxiety disorders, that means that the anxiety is not secondary to an underlying medical condition, such as hyperthyroidism, and also not linked to the acute effects of a substance or medication. The most prevalent anxiety disorder is generalized anxiety disorder. We might also be familiar with panic disorder, post-traumatic stress disorder, acute stress disorder, social phobia, and other anxiety disorders that we'll explore much more in our dedicated psychiatry course. Generalized anxiety disorder often describes a patient with excessive worries that last more than 6 months. It's defined by realistic worries and what-ifs about events that could happen. There are some screening questions here to ask. that you might consider. Now, these screening questions are also identified on the anxiety screener, the GAD-7, where GAD here might, for example, indicate generalized anxiety disorder, and 7 indicates the number of questions that we ask on this. This is a self-administered survey where a patient can fill this out, say on a clipboard or an iPad or something similar to that, and the score is totaled to give us an overall severity of their symptoms over the past 2 weeks. I think that's an important part of both this screener and some of the others that we'll be talking about, is that this is about current symptoms. It's not asking did this happen 6 months ago or 6 years ago. This is about the last 2 weeks. Now let's talk about depression. Again, depression is a symptom. It is not a diagnosis. If you were to tell me major depressive disorder, that's a diagnosis. Almost 7% of the adults at any given time in the United States have major depressive disorder. It's frequently comorbid with anxiety, substance use, and chronic medical illnesses. You'll be looking out for a patient who might have low self-esteem, anhedonia, there's that vocab word we spoke about earlier, describing a loss of pleasure in daily activities, sleep problems, and or difficulty concentrating. There are some screening questions that we'll get into, but what you need to know is that these are on the PHQ-2 and PHQ-9. Now, PHQ stands for Patient Health Questionnaire, and this is a great screening instrument to ask about on multiple choice exams because the words patient, health, and questionnaire don't say anything about depression, which is what the screener helps us do. The PHQ-2 is a 2-question initial screening for depression, and if a patient has a positive score, if they say yes to either of those questions of, over the past 2 weeks, how often have you been bothered by little interest or pleasure in doing things? Over the past 2 weeks, how often have you been bothered by feeling down, depressed, or hopeless? That triggers often a need to do the PHQ-9, which is a more in-depth version of the depression screener. Now, the PHQ-9 and PHQ-2 in general can be self-administered, where again a patient can respond to these, and for many of us who have gone to a primary care visit and been asked to fill out something in the waiting room or online before our visit, it's often a PHQ-2 and or 9. It is possible and totally fine to go straight to a PHQ-9 without doing a PHQ-2. Please note that the PHQs are self-evaluations. If a patient says they're experiencing something severely or nearly every day, we go ahead and record that. Now that's different than the Hamilton rating scales for depression and anxiety, the HAM-D and HAM-A, in no way related to Lin-Manuel Miranda or the musical Hamilton, but these are going to be more objective rating scales that are scored by the physician or clinician, and they're considered, again, more objective because a physician can alter the responses a bit based on the overall patient presentation. Now the PHQ-9 consists of 9 questions that in general run us through this mnemonic of remembering how to screen for depressive symptoms. This again is something that every first-year med student gets to know and memorize, and that's this mnemonic SIG-E-CAPS. Now, SIG-E-CAPS runs us through changes in sleep, interests, guilt, energy, concentration, appetite, psychomotor changes, and thoughts of suicide. You can look at the questions on the PHQ-9 to get a better idea of how we might ask about those and what those different symptoms mean. Again, if you are in an OSCE or doing a patient interview and you want to screen for depression and you don't have a PHQ-9 near you, knowing SIG-E-CAPS and knowing to ask for these questions will help you identify the symptoms that are listed in the DSM-5 for a major depressive episode. Moving on, we're going to take a look at substance use disorders. For substance use disorders, one of the most common tools and screening instruments that students will use is the CAGE questionnaire. The CAGE questionnaire is originally developed for alcohol use disorder, which at the time was called alcohol abuse, and the CAGE questionnaire can be applied to any substance or addiction pattern. It asks questions about needing to cut down, people being annoyed or criticizing the behavior, how often the person has felt guilty about their behavior, and if they've had to engage in the behavior, in this case alcohol, first thing in the morning, an eye-opener. We have to remember that alcohol use, including binge drinking, is incredibly common in the United States, as is illicit drug use, with each of these respectively representing about 1/4 of the population to about 1 in 10 people, depending on the substances. So these are going to be questions that are incredibly common and things that we want you as a medical student to be very comfortable asking about. Now, every student doctor should also have an idea of general risk assessment. Suicide, we may recall, is the 12th leading cause of death in the United States, but most concerningly, it's the second leading cause of death among 15 to 24-year-olds. The rates are highest in people ages 45 to 54, and then it's followed by our greater than 85-year-olds. The risk of suicide is also particularly concerning in marginalized and vulnerable populations. Completed suicide rates are much higher in men than women. However, women are 3 times more likely than men to attempt suicide. A screening question to ask is, have you ever thought of harming yourself or others? And have you ever attempted suicide? Please remember that asking about suicide or homicide, including harm to self and harm to others, which may not entirely overlap with suicide or homicide, does not make a patient more likely to ask upon those thoughts. You should be familiar as well with the 1976 Tarasoff case, also known as a duty to protect. This applies when a patient makes a threat to a physician or therapist of serious violence or bodily harm against a reasonably identifiable victim. In this case, the physician may break confidentiality in order to protect the other identified person. Remember our vocabulary words here. When we're doing an assessment in terms of homicide or suicide, it's important to ask about intent, plan, and means. On this slide, feel free to pause and take a look again at clearer definitions of what intent is, what plan is, and what means may be in order to fully document risk. Memory loss is also something that I'd like us to be comfortable with screening. Memory loss is, for the most part, different than benign forgetfulness, where a person, especially an older adult, might have some difficulty recalling specific names or details of events, as well as distinguishing from age-related changes. Now, mental health diagnoses like depression, dementia, and substance abuse can cause functional impairment, which is different than common age-related changes. If you do notice a person having difficulty with their functioning, with their abilities to complete their activities of daily living, or their instrumental activities of daily living, their ADLs and IADLs, that's when we need to be more concerned and pay more attention. On this slide, I do have definitions for dementia and delirium, and you should be very familiar with the differences between dementia and delirium at a very basic level. In lab, we'll be going over the mini mental state examination, which is widely used to screen for cognitive dysfunction and dementia. Now, this exam is proprietary, but you should be familiar that it exists, and in general with the concepts that are emphasized on this exam. Please note that the mini mental state examination, or the MMSE, is different than the MSE, or the mental status examination, that we'll be talking about a little bit later in this presentation. You should also be vaguely familiar with the MoCA, or the Montreal Cognitive Assessment. This is also a proprietary examination, but one that you are very likely to see on your clinical rotations. This helps to evaluate patients with memory loss or other cognitive dysfunction, and is very similar and overlapping with the MMSE in many different ways. This does include visuospatial elements a little bit differently, and also is a little bit more visually pleasing as a one-page document for the screener. Again, the mental status examination, or the MSE, is different than the MMSE. The mental status examination is the specialized exam for psychiatry, and common components of a mental status examination are going to be things like the patient's appearance and behavior, their speech and language, their mood and affect, their thoughts and perception, their cognition, their insight and judgment. And here's a couple additional vocab words where insight describes a patient's awareness of themselves and their condition, and judgment refers to the person's ability to use that insight to keep themselves safe or to carry things out in their own interests. You should be familiar with common components of the mental status examination and know what terms might be used to describe different things. For example, thought process might describe how a patient's thoughts are connecting. A patient with a tangential thought process might start with an idea and never quite finish that idea because they start talking about all sorts of different things. Whereas, say, a patient with a circumstantial thought process might just take a really long time to get back to their point, but like the circumference of a circle, eventually they make their way around to it. Psychiatry includes an incredibly rich vocabulary of all these different words that describe a person's mental status. When I'm working with medical students and residents, I like to describe the mental status examination as being detailed enough to where if you were to walk into a busy waiting room of patients, you'd be able to pick out the exact patient that you're talking about from the mental status examination because it would be that detailed. I also want to talk about the language of medicine. As future physicians, it's incredibly important, even starting in first year of medical school, to remind ourselves to not use stigmatizing language, particularly around mental health topics and around patients with psychiatric presenting concerns. I'll emphasize again that, in my opinion, there is no such thing as a psychiatric patient. However, we do have patients that utilize psychiatric services or present with psychiatric symptoms. Remember again from earlier in this presentation that an overwhelming percentage of patients in primary care settings and emergency room settings have psychiatric complaints. One way to check if we're using the best language in medicine is to use language that puts people first and not their diagnoses. We should also use language that views psychiatric and substance use disorders and their treatment as medical, promotes treatment and recovery, and avoids negative stereotypes and biases. For example, instead of saying a schizophrenic, we might say a patient with schizophrenia. Instead of saying a patient who's addicted or has a habit, we might say a patient with a substance use disorder. Instead of describing a patient as non-compliant or compliant, we might say they're adherent or non-adherent. We want to avoid the use of words like clean or dirty to describe a urine drug screen, but instead say specifically the urine drug screen was positive for, say, cannabinoids and opioids, but negative for cocaine and amphetamine. I also want to encourage you to move away from the language of saying a person commits suicide or committed suicide. We can say a patient died by suicide. We want to avoid using the word commit because that might imply that dying by suicide is some type of crime or has some type of further legal implication. I've listed some of my references on this slide. I want to genuinely thank you for your attention in reviewing this overview of psychiatry. Again, the purpose of this certainly isn't to teach anyone a 4-year psychiatry residency in 23 minutes, but it is to give first-year osteopathic medical students an overview of psychiatric terms, conditions, and screening tools as part of a general clinical skills course. Please contact with any questions, and wishing you all the best in your educational journeys.